Thank you, Dr. Parker, for the nice introduction. And in fact, I was just talking to Dr. Park that I'm amazed to have such an audience, because I was thinking of such a handful of people showing up on a Good Friday afternoon. Yeah, so thank you guys for showing up for my presentation. And today I'm just going to present to you my research, and basically my research about tobacco control. And of course, when I talk of tobacco control, it's my passion, and I live it daily. So please, if my passion comes through, that's how the field is. Okay. And this is the overview of my presentation. I'll present to you my research approach, because I'm doing a lot of other kind of research within this approach. I'll give an idea of what I've been doing for the past 22 months that I've been here at ETSU, some of the work that I'm currently doing, and the future direction of my research. Okay. I always like starting any kind of my presentation with this slide, because that's the essence of health, and that's the reason why I'm involved in tobacco control. If you look at this, this is a picture from the Surgeon General latest report. That's the 2010 report. And you look at this, you see smoking and secondhand smoke. You have smoking has a whole lot of cancer, just affect almost all parts of the body. We have the effects of secondhand smoke on children and adults. But what is interesting is that I came across, in the course of my research, I came across a data that shows that in Tennessee, about 50% of the household, they don't know that there's a relationship between secondhand smoke and SIDS. So that's something interesting that I always like to point out. But beyond just the morbidity issues, there's also health aspect of tobacco use. And these are just conservative values. I've just tried to just use the lowest numbers. And you look at it, in Tennessee, on average, tobacco is related to about 9,700 deaths per year. In the U.S., it's about $443,000 deaths a year, and globally it's over 5 million deaths a year. But what is interesting is that when we look at the current trends compared to the previous trends that we saw in 2010, when during that period, tobacco killed about 100 million people. So we look at that trend and compare it to this trend. The WHO came out with an estimation that is going to kill about 1 billion people if the current trend that we saw in 2010 is just going to continue through 21st century. So, but there's also an economic aspect to it, because at the end of the day, people said, okay, we don't want to give out tobacco. If we give out tobacco, what is going to happen? Economic argument, and people look through the issue through economic lens. But there's also cost to what? Tobacco use, economic cost. And these are some of the estimations from the CDC. And according to CDC, between 2000 and 2004, Tennessee incurred $5.1 billion in terms of medical costs and lost productivity. And in terms of the entire country, U.S., you have $193 billion as cost from tobacco use. And globally, it has been estimated, this is a rough, as I said, conservative estimate. It's costing about $500 billion worldwide. That's $500 billion. And this is the reason why and how I approach the study and how I approach understanding tobacco. And basically, I use what the WHO came out with. It's called the social determinants of health. And in this framework, we have the environmental context. So we have the societal context. We have the governance, rules and regulations. We have policies that we make. Then within it, we have cultural and societal norms. And these issues affect our usual suspects, demographics, and other social positions. Then these intermediary variables affect our what? Our behavior, and of course, in the end, come out with this issue of what? Health. So the idea, and my idea, is how we can influence this, to be able to influence these intermediary variables, influence our health behavior and attitudes, and get what? A good health outcome. So that's been my framework and my model. So the entire goal is how to use policy to achieve a better health. This is my research framework and the model that I just developed, because I do some form of work in global tobacco control as well as domestic tobacco control. And at the global level, we have what we call the WHO. And the WHO is, of course, the main international organization in charge of health. Then we have the UN, but within the UN too, they have a body called the Interagency Task Force on Tobacco Control. And this is an agency made up of about 40 organizations, including including UN agencies and other international organizations. Then under the WHO, we have the technical arm called the TFI. We have the governing body called the Conference of the Party. Then we have the administrative body. And beneath it, we have the parties or the states that constitute the system. Then we have the observers within the system or under the WHO rules. We have the 6 WHO regions. Under this one, the administrative side, we have the office of the secretary, and we have other branches helping the office of the head of the secretariat. Then, under the technical arm, we have collaborating centers, like the one Dr. Park mentioned about. That's the center at UCSF is one of the WHO collaborating centers. So they are spread all over the world. Then we have states. Then we have organizations. We have other organizations, and of course, we have our localities. And this picture is just to give you an idea that my framework is all about institutions, individuals, actors, and processes. What is my approach to this kind of research? I use 3 main types of approach. At a qualitative level, I use what is called triangulation. And triangulation is just a matter of using multiple sources of data. And so far, my major sources of data has been the tobacco documents. And these are over 50 million documents that the tobacco industry released. And these are internal documents. And I can just give an idea what those documents are. So those documents are based here. You type in Tennessee, and boom, you have 129,000 documents. All about Tennessee. And it's all about tobacco use and tobacco control in Tennessee. So this is the big, huge data set. And it's, every day, they are adding more documents. So I use that one, and I use also interviews, which is a big part of it, and I use observations. The other one is the mixed methods. And the mixed methods, usually, the idea is I have the policy, and I usually do for some form of standardized index. Then I code the policy along those index. Then I relate those policies to some of the qualitative data that I will be able to collect, to be able to determine associations and relationships between those policies that I've coded and those quantitative data. Then the other aspect is this quantitative, which is purely quantitative approach, and I use basically a survey kind of work that I continue to do since I came here, and secondary data. So those are the big framework, my goal, my framework, and my research methodological approach. So then what have I been doing over the past 22 months since I came here? The first one, I just want to introduce you to this framework, because as I told you, we have the global level. That's where my research was centered when I was in UCSF. So at the global level, we have what we call the WHO Framework Convention on Tobacco Control. And it's basically what I refer to as International Tobacco Control Treaty. And the treaty has currently been signed by 172 members. Of course, US, which has most of the policies, and most of the treaty was based on main policies from places like California, Massachusetts, and Minnesota. But interestingly, the US is yet to sign the treaty. But within the treaty, everything in it is trying to use policy to achieve a better health outcome. And they use the main approach of these treaties. We call one side is called the demand side approach. Then the other side is called the supply side approach. And just because you cannot only control supply, you have to also control the issue of demand. And these are the main demand suggestions. And these are, they call it proven policies, because over and over they've seen that advertising works, health warning works, taxation works. There's a big inverse correlation between taxation and tobacco use. You jack the price of tax on tobacco up, consumption among usually youth just decline. So there's that strong inverse relation. Then, of course, there's smoke-free environment, which is one of the most powerful tools around the world today. By creating those environments, by having regulation to create those environments, it just forces people either to quit. And we have also health campaigns, and health campaigns usually entails education. And who has seen the Truth Health campaign by Legacy Foundation? The Truth. Okay. It's a typical example of trying to inform the public. And since the Legacy had that campaign, there's been a whole lot of evidence that it worked, just informing the public about even the tobacco company, how the tobacco companies are doing to manipulate people works. Then we have to also talk about the supply side. And the big issue here is try to ban the sale of tobacco to minors, control illicit trade, which is a big issue in the world now, illicit trade in tobacco. Then keep in mind, illicit trade is also related to what? Criminal activities. Basically, there's been an evidence linking illicit trade in tobacco to terrorism. Okay? There's a whole lot of evidence linking those two. Then there's the issue of trying to help people who are saying they are going to stop farming to find other sources of livelihood. So it's a whole composite of policies and programs. Okay. So I've done a lot of research on them in my previous life, but over here, what I did was I tried to examine this policy, and examining the entire policy, there's one big issue in international relations called international trade. Okay. We want free trade. We want liberalized trade. We want things to move freely across national borders. But is it good to have a trade that may adversely impact health? So that's a question that states have to answer. And during the negotiation of this FCTC, one issue that came up, they talked a lot about it, but couldn't reach any consensus, was trade. How are we going to deal with international trade? After all, tobacco is a legitimate product. And if it is a legitimate product, we can freely trade it. And the World Trade Organization just has accorded tobacco a legitimate status. Because under the Uruguay round of talks, the talks between 1986 and 1994, that led to the WTO itself. They just discussed a whole over 8 years of negotiation, and that involved tobacco. So I said, why if that we know that trade has negative effects? So in this treaty, why is it that we didn't have any kind of policies or programs? So what I did was to go to WHO, spend 6 weeks over there going through negotiation documents. And what I came with was one of the key conflicts during the issue was, do we want health to take priority over trade, or trade to take priority over health? So in case a commodity has a negative health impact, do we have to say we are not going to trade it, or what? So the big finding was that of course, it was a political process. We have big countries who said, like the US, the European Union, and even Canada and Australia, they are big trading partners. They don't want anything that will affect what undermine international trade. But the other interesting thing was that even the health people also even couldn't agree among themselves. What language are we going to have in this treaty? So because of these big issues, they couldn't agree on anything. And this one, I just want to show you as an illustration of the issue of illicit trade involved in international issues. You look at it, we have the country of Paraguay. We have 67 billion cigarette smuggled out of Paraguay. So most of the products that they have are not legitimate commodities. So what are we going to do about trade? They couldn't agree on anything. So they just have to kick the whole issue forward. Just, I always call it just pound the ball. They just couldn't agree on anything. Just pound the ball. Okay, let's forget about it and move on. Then this paper that I did was published this year in tobacco control. That's one of the top journals in, of course, area. The other issue that I also I've been doing since I came here was the issue of Malawi. And I use this, basically use this tobacco documents, trying to examine how the tobacco industries have been using Malawi in global tobacco control. And the main reason why I chose Malawi is that Malawi is one of the highly dependent tobacco countries, dependent countries in the world, in the sense that they derive 64% and above of their foreign earnings on tobacco. So it's a highly dependent tobacco country. So what we did was to try to understand the policy environment and understand how the tobacco companies, which dominate the policy arena in Malawi, influence the key policymakers. And these are the policy recipients of the country, and how this interaction affects Malawi's role in global tobacco control. And what we found was that these companies just get together, have a stronger relation with the policymakers, and whenever their Malawi delegation is going to any kind of international negotiation, they put their members on board of the negotiation. So when they were talking about the FCTC, Malawi was one of the big opponents. All that they were screaming was that, what are we going to do with that? So when you look at the provision on alternative sources of livelihood, I always call it Malawi's provision, because it was Malawi that proposed that provision. And Malawi said, if you are not going to do anything, we just keep screaming and screaming about it. So Malawi, because of its dependence on tobacco, has become tied to the tobacco industry. So the idea is, how are we going to separate the two alliances so that we'll be able to have a very coherent kind of a global policy and a coherent form of global consensus. And I tell you personally, as an observer of this negotiation, that the Malawians are very aggressive because they have resources. When I was in Uruguay in November, they had a whole contingent of people from Malawi. And all those people were tobacco people. And they were just sitting right in front of me. And all that they were just trying to do was to disrupt the negotiation. So that's the personal aspect. But this one was also published in AJPH. Okay. The other aspect that keeps coming up is the issue of non-communicable disease. And the issue became a concern because I'm a policy guy, and they usually draft me into some of these health-related issues. And this big issue came up last year during a United Nations meeting. We have what? The issue of non-communicable disease. Over the past 20 years, there's a trend going on showing that these are the emerging diseases in the world, throughout the world. For so many years, we thought it was developed country issues. But increasingly, it's becoming also what? A developing country issue. And as at now, about 60% of all death in the world is attributable to these 4 diseases. So these guys just came up with identify the key policy interventions. And the question was, okay, we know the causes of these non-communicable diseases, tobacco use, issue of diet, obesity, harmful alcohol use, and we have these cardiovascular diseases. We know all these interventions. We know the expenditure on them. What are we going to do? So my role in this was to try to find a way and ideas of how to foster collective action among countries. And these are some of the things I and my collaborators came up with. And one of the things we were talking of was the issue of making NCDs more visible, making it more apparent, not focus only on infectious diseases, but also NCDs, chronic diseases. We also talk of the issue of UN leadership, the issue of trying to coordinate governmental and non-governmental activities around NCDs, make NCDs part of the development program of the UN. We have to mobilize more resources and do a lot of research because we have research is lacking on this issue. Then we have to also nationalize some of these policies and programs. And this paper is coming out in Global Public Health in a couple of months. So beyond that is another work that I've been doing, and this has taken me 4 years, and I'm still struggling to get it published. It took me 4 years to interview about 46 people from about 30 countries. Yes, to be able to get their ideas and be able to pull this together. What I did was try to see, okay, these people in tobacco control around the world, what is driving them? That was my big question. What is the ideas driving all these kind of people who are passionate about the issue? So my interview, at the end of the day, I have 91 people who identify themselves as scientists, researchers, and advocates. We have people, only 2 said, okay, for me, I do only scientific work. Others said, we are in government, but we are in government as experts in tobacco control. Others said, we are just pure advocates. We don't want to do anything with the science. You go and crunch the numbers and give it to us, and we know how to deliver it to the policymakers or influence them to change their attitude. So somebody like me, I will find myself here because I'm interested in research, interested in also advocacy. But these are the key issues that I'm involved in, the issue of what? Policy. That's comprehensive. So those are the comprehensive policies, are the composite policies I showed you earlier. So these are the stuff that I found in trying to code all these interviews. At the end of the day, I had 181 interviews. I code them in NVivo and came up with these conceptual breakdowns. Okay, I have the core values that are driving these people include the idea that tobacco kills. There is also the idea that the industry is what? The mosquito in the spread of tobacco. Because if there is no tobacco industry, there is no tobacco use. So if you want to think about mosquito equivalent of what? Equals to malaria, then you can think of what? The tobacco industry as what? Equivalent to what? Tobacco use. So that's the mosquito in tobacco use. Okay, but the difference is that mosquito is not a lobbyist, but the tobacco industry is a lobbyist. So that's the difference. Then these are some of the consensual. I came up with 5 consensual knowledge that is driving this field. And consensual knowledge, we know, always emerge over a long period of context. Okay, you said tobacco what? Kills. Show us the evidence. So it takes a long time for people to agree that, oh, there's what? Even when you talk of secondhand smoke, it took a whole over 50 years before there was a consensus that there's what? A relationship between secondhand smoke and what? All these illnesses. Then they used different approach to what? This scientific work, they use biomedical research. Of course, I'm here, policy research, and of course, historical research too as well. Then these are the policies that many of them pursue, including me, and these are the way they try to influence the outcomes. Use inside strategies like lobbying government. Some people are within the government institutions, so they work to change government policies. Others also work outside government. I work outside government, so my only thing that I can do is publish papers. And just to share with you, one of the papers that I published, somebody out of the blue said the U.S. trade policy need the international trade paper because they are trying to gather information on how trade affects health outcomes outside the U.S. So I have to send it to them. I met somebody at a conference in Chicago recently, and the person told me, Hadii, I'm going to meet some policy guys in Australia, and one of the issues is your paper is on it. So I said, okay, thank you. Yeah. So those are the outside kind of stuff. But this is a paper that I've worked on it for the past 2 years, but it's tough to get published just because we cannot agree on some of the stuff. And now I have only one reviewer to convince out of 4. So I'm still trying to work on that. Then this is the book project Dr. Park just told you about. I've been working on this book also for the past 2 years. And it's a 10-chapter book. And it's a collaboration between myself, my PhD mentor, and one guy in UK. And it's a 10-page, 10-chapter book. I'm one of the editors of the book. And I've 2 chapters. I just wrote 2 chapters by myself. I co-authored 3 chapters. And of course, the book, the last email I had was it has approved for publication. So it should come out sometime this year. And that will be the first political science book on tobacco control. Yeah. So that's, it's been a long process, but we're gradually getting there. So again, this is the framework that we used. There are different levels of the policies. It occurs at the international level up to the domestic level. So those are the issues. And they are integrated. And think in terms of this way. These localities in US, we usually call them the engines of innovation. That's where we test the policy. That's where we gather the evidence and be able to use it to influence policy change. This is an example of, just to give you an idea of how all these activities that people have been engaged on over the past years have been working. Since the FCTC came into being, this is what has happened. Look at the health warnings around the world. Now you go to Australia, these are what you are going to see on cigarette packs. You go to UK, these are what you are going to see on cigarette pack. Instead of the nice lady, the camel man, you're not going to see them anymore. These are the actual stuff that you are going to see. And even in the US, though the US is not signatory to the treaty, the US is not, FDA is now considering these health warnings so that we are going to do away with that teeny surgeon and rather have these graphic warnings. So these are the graphic warnings the FDA is now considering. So in about a year or 2, FDA will just require all tobacco companies to have these kind of warnings on their cigarette packs. So those nice ladies, those nice men, energetic, we are no longer going to see them. And it's all because of this treaty. But beyond that, there's also changes around the world. And some of these changes, this was in my the one chapter that I wrote for the book. And if you look at it, you see the first data point was 1997. And the last data point was 2009. So you look at them, over all the policy areas, there's been increase in the number of countries with those policies. So the world, there's a continual though it's slow, but there's increasing transformation of tobacco control around the world. Those are my global kind of work. So now, since I came to ETSU, I've also had big interest in domestic tobacco control, and mostly because I just came and found out that over here in Tennessee, the smoking rate is way above the national average. For example, currently, last year, the smoking rate was, I think, 17.9 for the national average, and it was over 22 for Tennessee. So there's that big gap, and how are we going to close it? I'm now a Tennessean, so I have to contemplate of how to close that gap. And one of the venues I've seen that we can use to close that gap is tobacco-free campuses. And I began interest in these tobacco-free campuses because I came across my first interview here. I realized that, geez, in the middle of the woods, we have a school called ETSU having this unique tobacco-free policy. What's going on? Can we replicate this policy over the school system so that it will, at the end of the day, improve health? So those are my big questions. The first aim is to evaluate the policies around the state. Then try to see the linkages between some of the institutional characteristics, community characteristics, and these policies. And one scale that I'm using is a CDC scale. And the CDC has developed a whole slew of policy that you can code. So you take ETSU, you can code ETSU policies along this scale and come up with a measure. And that measure will tell you whether the ETSU has a strong policy, a weak policy, or even what we call, no policy at all. So that's the scale I'm using. And so far, the last time we did some form of coding, and we coded 45 institutions. And the 45 institutions, ETSU is here. And even in ETSU, it's still low because it's a 40-point scale. So you consider the ETSU policy is still low. So these are the 40. We have about 100 institutions in the higher education system, and we are still coding the policies to generate this map. So beyond that, last spring, I decided to do a study for just ETSU employees. And this is the first time I'm publicly sharing some of this information to an audience like you. So my goal for doing that survey was to analyze the attitudes and behaviors of ETSU employees towards the tobacco-free policy. And interestingly, 82% of all the respondents, the response rate was 58%. Okay, so out of the about 2,300 people, we had about 1,177 response to our survey. So it was a higher response rate. And out of those, across all categories, there was a high level of support for the policy, but 82% of the people said, okay, we are good with the policy. Then we tried to find some associations between the policy and some of these usual characteristics. And these are some of the findings that we find in a survey. We found that women support the policy more than men. We have faculty support the policy. Faculty and professionals support the policy more than other people. We have people in medicine and, of course, health sciences support the policy more than the College of Arts and Sciences, and so forth and so on. Then, when it comes to the issue of the only people that oppose the policy are the current or ever smokers. So this is, in a way, consistent with the general trend that we've been finding in some form of policy study. But what is interesting is that about 80% of the people also reported the issue of non-compliance. And this one, I've not yet done a big work on it, but it's also interesting that the policy, in the data that we did, we asked a question about the change in their behavior before August 2018 now. And we found that about 20% of the employees said we've either reduced the number of cigarettes that we smoke, or we've just even stopped smoking because we just can't deal with the inconvenience. And so that's a positive impact. If you can have 20% decrease in smoking rate over a 2-year period, I think that's very important information. But this one too, I'm working on resubmission to a health education journal. But interestingly, this is a picture somebody sent to me. Somebody who just took the survey. Just, you see, said, I should see the lady with cigarettes. Yes, the person was just so said, we have a good policy, but we are not what? Implementing it very well. So that's how the person sent to me. Okay. Beyond that, there's other components of the analysis that I did, and these are just summary statistics and issues of prevalence. And interestingly, we have 9% prevalence rates among the respondents. That's only 9% said we are current smokers. We currently smoke. Then we have 2.7 said we use other tobacco products. Then we have 11% said, okay, we've used other. 44% actually said we have smoked before. 11.4% said we've used other tobacco products before. But interestingly, we have women smoking as twice as men. And I don't know why. Because within the people who reported that they are smokers, about 64% of them said they are women. So that was an interesting finding. But the lowest rate of, the highest rate of smoking is among people between the age of 30 and 39. Then the lowest is among faculty. And of course, there's nobody in College of Public Health who said, I smoke currently. Yeah. So, but the big issue here is that this information are very relevant for policy development. If we are going to make any kind of policy, we can target this group because that's where a lot of people would smoke. And of course, the evidence also shows that there is some form of relation between socioeconomic status and tobacco use. As you can see, people, the faculty administrators who are highly educated, smoke very less, support the policy stronger than the clerical staff and other kind of supporting staff. Okay. So this is also a manuscript that we are working on it and shopping it around to find a publisher. Okay. So that ends my other actual work that I'm doing. So these are the current stuff that we are doing. And I'm still continuing with the global tobacco control kind of stuff. But in this case, last summer, we spent a whole summer trying to clean this global youth tobacco survey. And we did a lot of cleaning. We've already had a data set, and we're trying to crunch some of the numbers and papers out. But one paper that we looked at so far is the adolescent support for smoke-free policies around the world. That's within a 45. It has 54 core questions, and only one deals with what policy, and the policy is about smoke-free policy. So we did the analysis with at different level, and basically we did some form of summary statistics and logistic regressions. And these are the key findings. We have about 74% of the adolescents in the survey said they support smoke-free policies. And these are some of the key determinants. The smoking status. People who smoke opposes the policy, just like we found in the ETSU. People who are knowledgeable about secondhand smoke support the policy stronger. People who said, okay, secondhand smoke is harmful to me, are more passionate about smoke-free policies. Then there's also the issue of familial relation, and that involves how people, the smoking behavior of their parents, the smoking behavior of their peers affect their opinion about our policies. We are also working on this as a completed manuscript, and we also shopping it around. I had a whole conversation about Dr. Park about some unfortunate thing that happened with this paper, but we're still working on it. Then the other part of this Global Youth Tobacco Control Project is the issue of Ghana. We need more country-level kind of analysis, and of course, I decided to choose Ghana just because I'm from Ghana. There's nothing special about Ghana. I just chose Ghana to understand what is happening there just because I'm from Ghana. So we try to understand the tobacco prevalence among the youth, and we found that they have a very low prevalence rate. But what is interesting is that people who own tobacco products smoke more. So that's very interesting. People who are exposed to tobacco industry products, advertising, smoke more. Then, also, interestingly, and this may be more cultural, in households where the parents smoke, they also smoke. Then we have the media, and the media is the significant effect we find it only among female. Female exposed to the media are more likely to smoke. But also with female is something interesting. If they feel that their cohort or their colleagues look attractive by smoking, they appear nice, they have good social relations, they tend to smoke more. So this is also a manuscript that we are still working on it. This is my piece, and this piece emerged from my travel to Uruguay. And my travel to Uruguay, remember, I've already published the Trade and Health issue, part 1. That was already in tobacco control. But there's also part 2 that occurred during my stay, I think a week stay in Uruguay. And I observed it. I was in the back room when they were cutting the deals on the language of the policy. So I have the data set, and I'm trying to code the information that I've gathered. And so that's another issue. Then the other issue is also the same stuff. But what I found in my travel over there is that at the negotiations, we have 2 committees. We have Committee A and Committee B. Committee A deals with substantive issues. So are we going to have tobacco-free policies? Yes or no? Are we going to have advertising campaigns? Yes or no? Then Committee B deals with the actual monetary issue. But what I observed was that most people during the negotiation were concerned with Committee A because they thought that's where the action is. Because if you want to have a policy on taxation, you need to have Committee A to have the policy. But the trick that I found was that even if Committee A makes any decision, it has to be a line item by Committee B. So you go to Committee B, it's an empty room. Okay? You go to Committee A, you wouldn't even find a seat. But at the end of the day, when it came to the plenary, most of the decisions that we made in Committee A wasn't accepted, and it wasn't approved in Committee B. Just because it wasn't a line item. So my idea was to try to eliminate this finding during my observational study over there. So I have the data, and I'm working on that as well. So this is an example of the observational study. These are my materials. This is the speaker. We were negotiating. Everybody was raising their hand, talking. I have all my recording materials with me. And this is an environment where, during the negotiation, if you look at it, you've seen people cutting backroom deals. And this is the most interesting part. This is the Chinese delegation. This is the European delegation. They couldn't agree. There was no consensus on one issue. And they have to find a way to find a middle ground. So they gave us 5 minutes, and people have to caucus among themselves to find a middle ground. So at the end of the day, the European Union and Japanese cut a deal with China. And the Chinese delegation eventually came in so that we will be able to have some form of consensus on the policy. So these are the graphic images. I can use the NVivo to code all this standing and what is transpiring over here. Then the other one, these are other stuff that I was dragged into it, also because of my international kind of stuff and my policy orientation. And this was a big issue of menthol that happened during my observational study. The issue is they put menthol as what? Flavoring. And what does it do to make sure that the tobacco is not harsh, so that people will be able to inhale the tobacco without feeling the harshness of tobacco? And it's been very powerful tool for the tobacco companies in recruiting women in particular around the world. So one issue was, for example, in the Middle East, the women didn't like smoking the hookah, because it was so hard for them to just inhale the hookah. They didn't like it. So for that reason, the smoking rate was down. Now they've added the menthol. So it is now even attracting them to the hookah. And even beyond that, they have added some form of flavoring. Like it's now one delegate from the Middle East said, so many years we thought hookah was just stinks. We are women, we want something that is nice. We don't want to get near them. But now they've added some flavor that make it smell nice. So it's no longer stinking and harsh to smoke, but it's now even smelling nice and very soft to what? Inhale. So that's a big issue, and because of my observational study, I was also dragging the ring. And of course, we are also working on these NCDs because it's a new issue of collective action. And I was one of the few people to publish the first articles on this kind of collective action on the NCDs. Okay. Back home, I had an RDC grant to do stakeholder analysis of the ETSU, the Tennessee Non-Smokers Protection Act. And my research question was why and how in an economy, in a country where we have tobacco as integral part of what? The society, the culture and everything, still policymakers came together to develop one of the first statewide smoke-free policy in the country. So that was my big question. And we have done 29 interviews, and these are actual, I call it the inner circle groups, the people who were actually involved in the room negotiating the policy. We are now coding the information that we've gathered. So at the end of the day, we'll be able to come out with some information. But what I've already done was this information that I've already gathered. The question is, why did even Tennessee decided to consider a statewide smoke-free policy? Why did they even consider it? They've ignored it for so many years. So why did it suddenly become an issue? So that's the big question. So we call it, in the policy terms, we call it the agenda setting. Before the issue, they even go into the room, try to draft the bill, try to draft the legislation. We call it agenda setting. So why did it even happen at all? And from my preliminary finding, these are some of the issues. This is a political framework. We have three kind of streams. We have what? The political stream. Those are the individual relationships. We have the problem stream. What are we confronted with it? And we have the policy stream. And under this framework, both should come together to create what is called the window of opportunity for a policy to emerge. Okay, so under this stream, these are some of the issues that we've found. We have organized interest in the state. We have the governance support for the policy. We have legislative champions, and of course, we have the media that was also in support of the policy. And most importantly, we have the public, because at that point in time, over 70% of the public were in favor of some form of smoke-free policy for the state. Then we know of the problem. There's nothing wrong with that. We know that tobacco kills. We know that what has economic impact. Then how are we going to do with it? Or what are we going to do? But what happened was Governor Bredesen just brought a whole change, because Bredesen was inaugurating some form of they did, I interviewed somebody, the person said they did renovation of the state buildings in Nashville. And after the renovation, they didn't want people to be smoking in the building again. So they decided to go for what? Smoke-free state buildings. So when Governor Bredesen was inaugurating it, Bredesen said, okay, then we can what? Expand this nationwide. Then quickly, this coalition, we call them the opportunists. They are always there, looking for windows to open so that they'll just grab on it and what? Run with it. So immediately, Bredesen just made that statement. They just went to the media and said, okay, we are now going for what? Smoke-free policy. So all this came together at one point, then it resulted in what? The policy change. So before this, even we had a bill called the Non-Smokers Protection Act. These things have to happen first. So we are working on it still. Then the tobacco-free campuses, I'm still collecting data. Because my last study was on employees, and now I'm trying to expand it to students. And currently, if you are a student here, please go and fill my survey for me. And if you are a faculty, you can tell your student to fill the survey too. Currently, we are just collecting data on ETSU. And after ETSU, we've already had an IRB approval for UTK. We are going to do it for UTK as well. Okay. And the idea of all this, getting this information about these tobacco-free campuses, developing this code for this policy, code them in an order, whether strong, weak, or is to develop some form of what we call an interactive map, such that if I point a cursor at ETSU, I'll be able to get every information concerning the policy at ETSU. So that's the idea. After we've coded a policy, we will embed all the community characteristics and the school characteristics in the map. So that you just point it, it will just show up all those basic information about the policy. So that if you're a dad or a mom and you want to send your school to ETSU, you can compare ETSU to another institution here. And if you want to send your kid to a place where they have what smoke-free policy, you say, okay, I'm going to ETSU, instead of sending it to this institution. So that's the idea behind it. And if I get more resources, I would like to replicate it to other states. Yeah, but it all depends on resources. Okay. Finally, my future research. I'm still interested in the FCTC because I cannot run away from it. I've been working on it for the past 7 years, and for better or for worse, I'm one of the lead researchers on the issue, so it's very difficult for me to run away from it even when I want to. Yeah. So I'll still be working on FCTC-related issue, doing some form of country-level analysis. And this is the reason why we did the analysis for Ghana, just to give an example of some form of analysis that we can do at the country level to be able to make these policies meaningful to what? The individual countries. Then, of course, my mentor, Tom Novotina, has already drafted me into this non-communicable diseases project. So I'll still be working on this. And domestically, I'm interested on still working in tobacco control in Tennessee. Of course, my next project after this stakeholder analysis is to do some form of evaluation analysis. It's almost 3 years that we've had smoke-free policies. And so what? Does it make any meaning? Has it had any impact? That's my other, after this current project, that's where my next step over it. And as I told you, the tobacco-free campuses, I want to replicate what I've done for ETSU and Tennessee nationwide. And I always like to end with this thing. Tobacco use is bad, but stopping is also good. This is CDC diagram that shows people who decided to what? Quit have what? Improvement in their health outcomes. So it's not about only prevention, but only what? Also cessation. My idea up to this point has always focused on what? Trying to prevent. It's more preventive approach. But I also want to throw in this one that it's not just what? The prevention, but also what? Cessation. Because as of now, nationwide, we have over 46 million smokers. And if we don't help them to quit, they are eventually, about a third to a fifth, are eventually going to contract tobacco-related diseases. Okay. So these are the people I've been working with over the past 22 months. Yi, Smarty, Fanny, and of course, our lovely Brooke. Okay. So, any other question at this point? Okay, thank you all for coming here on Good Friday afternoon.